Hey there, my name is Jamie Carr, and this is my video presentation for BCIT's NSPN 7155, the Breastfeeding Theory course. The challenge that I am going to talk about is managing a dyad of a baby with jaundice and a mother with flat nipples. When dealing with challenges that occur with breastfeeding, it is recommended to use the situated decision-making framework to guide clinical decision-making in regards to breastfeeding challenges, such as working with a jaundiced newborn and a mother with flat nipples. This presentation will help us understand what jaundice and flat nipples are, how they affect the mother and infant, how to overcome these challenges with attention being paid to specific priorities, as well as how to evaluate the decisions for treatment. The situated decision-making framework is a framework designed to assist nurses in making decisions that foster the development of their knowledge, skill, and competence as a nurse. There are 5 main components to this framework, consisting of knowledge, cues, judgment, decisions, and evaluation of outcomes. Knowledge is when the nurse is informed of the case, the pathophysiology of the condition, and is able to determine when there is a problem, as well as what the patient's needs are. Cues are the observations and clinical data that indicate there is a problem. This includes observing the client and seeing if there are problems that need addressing concerns, knowledge deficits, as well as attitudes of the client. Cues also encompass physical medical evidence that further demonstrates that a problem exists, such as blood work results. Judgment is making a decision as to what could be happening to the patient based on the evidence gathered. Decisions encompass making a decision to start helping the patient and deciding if other members of the medical team are needed to get involved to help in implementing the care plan. An evaluation of outcomes. This stage is to evaluate to see if what was implemented in the decision stage helped the patient or if other measures need to be set up to further help the patient. For this project, I will be using this framework to discuss the breastfeeding challenge of caring for a jaundiced newborn and a mother with flat nipples. Breasts come in all shapes and sizes. There are 3 basic kinds of nipples, which is shown in the picture. The one that I will be focusing on is flat, which is when the nipple is flushed with the skin of the areola. Flat nipples are not that common. It is estimated that between 10 to 20% of women have flat nipples. It does cause some difficulties with proper latching during breastfeeding, but women with flat or inverted nipples can still successfully breastfeed. Because, after all, it is called breastfeeding and not nipple feeding. With some extra help, guidance, and some patience, mothers with flat nipples can breastfeed without the use of any special tools or gadgets. However, if mothers do have some trouble with breastfeeding, there is a possibility that the newborn can develop jaundice. It's a common condition in newborns. It is reported that 60% of healthy term babies and 80% of preterm infants are jaundiced within the first week. There is also a higher likelihood of jaundice developing in newborns who are being exclusively breastfed. Jaundice is the excess amount of bilirubin due to the breakdown of hemoglobin in a newborn. Bilirubin collects in the skin and mucous membrane, which leads to a yellow discoloration of the babe's skin and sclera. Bilirubin is a product of the breakdown of hemoglobin and when first produced is insoluble, also known as unconjugated. For bilirubin to be excreted from the body, it must be water soluble or conjugated, as unconjugated bilirubin is fat soluble and can potentially be deposited in the baby's tissues. To prevent unconjugated bilirubin being deposited in the tissues, it is bound to albumin, which is a protein, and then transported in the blood to the liver, where it is converted to its conjugated form by an enzyme called glucuronidase. Conjugated bilirubin is excreted into bile and then transported to the small intestine, where it's then broken down by bacteria in the intestine. A small amount is reabsorbed to be excreted by the kidneys in the urine, but mostly the larger proportion is excreted in the stools. The reason why jaundice occurs in the first place is due to a number of things. Initially, a fetus requires more red blood cells than a newborn to supplement oxygen delivery from the placenta. Therefore, when the babe is born, there is an excess of red blood cells that need to be broken down, and bilirubin is a byproduct of the process. Glucuronoltransferase, which is the process in which unconjugated bilirubin changes to conjugated bilirubin, is thought to be less active in newborns. These occurrences, in addition to the newborn's immature liver cells, result in higher levels of unconjugated bilirubin and therefore jaundice. This describes the first type of jaundice, physiological jaundice. This type of jaundice is very common. Like I said earlier, this is believed to occur in 60% of healthy term newborns and 80% of preterm babies. This type of jaundice is usually treated easily with no lasting side effects. The second type is called pathological jaundice, and this type of jaundice is more severe. This is when there is a significant buildup of unconjugated bilirubin and deposits in the blood, which is called hyperbilirubinemia. Unconjugated bilirubin, the kind not attached to albumin, is in excess, plus other risk factors such as preterm birth and low levels of oxygen at birth may open up the blood-brain barrier, and it allows the unconjugated bilirubin into the brain, which results in bilirubin encephalopathy or kernicterus. Kernicterus is when there is a yellow staining of the brain and can cause symptoms such as lethargy, increased tone rigidity, convulsions, deafness, and permanent brain damage. There are many reasons why jaundice occurs, most of them unavoidable. Such reasons include incompatibility of blood types between mother and babe, which can lead to rapid red blood cell breakdown in the infant, preterm birth of the infant, and congenital defects and malformations. Other reasons that may lead to jaundice in a newborn include improper breastfeeding, lack of support for mothers and infants who are struggling with breastfeeding, and a lack of resources to help with problems with mother and babe. Which leads me back into flat nipples and how to determine if you have them, as well as how to correct it. The pinch test is done to see what kind of nipples you have if you're unsure. It is performed by grabbing your breast at the areola and pinching the sides of your areola against itself to force your nipple to stick out. So you grab your areola with your thumb and forefinger and push in gently to enable you to pinch behind your nipple. If your nipple sticks out, you have what is called a normal nipple. If it is flush with your areola, you have a flat nipple, and if it goes further into your breast tissue and areola, it is said you have inverted nipples. A true inversion or flat nipple also does not protrude or become erect with cold stimulation, which is another way to test. How to diagnose and determine if the newborn has jaundice is determined on the signs and symptoms that the babe presents. To determine if a newborn has jaundice, a physical assessment must be done where the professional examines the child under proper lighting, either sunlight or good lighting, to look for yellowing of the skin, sclera, gums in the mouth, as well as blanching the skin to see if it's yellow. Other signs are lethargy, abnormal amounts of sleeping, poor tone, dark urine, and chalky white stools in the newborn. Another way to diagnose is to perform blood work on the newborn to determine the serum bilirubin levels in the babe's blood. This is done by way of a heel stick or heel poke to the newborn. So the challenge we have here is a jaundiced newborn and a mother with flat nipples. What is going on to make this situation occur? There are multiple things that can be happening, either with the mother, baby, or both, to create this situation. With the babe, they could be really sleepy and uninterested in feeding, which leads to less time bonding with mother and a prolonged time in between feeds. The babe may also not have a strong enough sucking reflex, or the mother and baby are having trouble latching. An incorrect latch may be due to the baby being tongue-tied or lip-tied, making it almost impossible for the infant to get a deep enough latch. An incorrect latch may also be another reason that contributes to this problem. Getting a proper latch takes time. It's reported that to achieve a consistent correct latch, it may take upwards of 4 to 5 days, long after the mother and baby are released from the hospital. The mother may also have issues with her breasts that impede adequate milk flow, which can include breast surgery, either a reduction or enhancement that has affected the nerves and milk ducts. Other breast issues that could be happening can include engorgement, mastitis, which is an inflammation of the breast tissue, as well as flat or inverted nipples, which makes latching and breastfeeding more difficult, which is what's occurring in this breastfeeding challenge. So now we know what is going on and why it's happening, so who can we turn to help with this jaundiced baby and mother with flat nipples? The family doctor would be a great resource to use because they would be able to properly diagnose the problem of jaundice as well as flat nipples based on the signs, symptoms, and the results of the diagnostic tests that were done. They would also be able to give the mother and child continual support throughout the entire breastfeeding experience because of the investment and relationship they have with their patients. A lactation consultant is an amazing resource to utilize, especially when dealing with a mother with flat nipples. The lactation consultant is a professional breastfeeding specialist that is trained to teach mothers how to feed their baby. They help women who are experiencing breastfeeding problems such as latching difficulties, painful nursing, and low milk production. They also help babies who are jaundiced and who aren't gaining enough weight. In this case, they will work with the mother to help her latch to effectively breastfeed the baby. Public health also has very good resources at their disposal for helping mothers and babes with breastfeeding. Trained nurses are able to give them tips and show them how to breastfeed the babe, as well as are able to monitor babe to ensure that the jaundice is clearing up and not getting worse. Support groups and friends or family are also great resources for mothers to utilize when they need extra support for their newborns. Being surrounded by people who are having similar problems or who are like-minded create a group of non-judgmental support for each other and work together to problem solve and create a conducive environment for learning, growth, and prosperity for the mother and newborn. There are 3 priorities that are pertinent to the situated decision-making framework, meaning that there are 3 things that must be done in this situation to ensure a good outcome for the jaundiced baby and the mother with flat nipples. The first priority is to feed the baby. As stated earlier, the only way bilirubin is excreted from the body is either through the kidneys or small intestine, so in order for the babe to pee and poop out the bilirubin, the baby must eat. According to WHO, it is recommended that infants up to 6 months of age should be exclusively breastfed. It is recommended that the baby eats every 3 hours or approximately 8 times in 24 hours. We can help feed the baby by increasing the frequency and duration of each feed, having more skin to skin to promote more feedings, and help the parent identify baby's cues for breastfeeding. Feeding the baby can either happen by way of breastfeeding, pumping, or hand expressing, or using donor milk. Formula is the last option and least recommended option. Breast milk is far superior and best for newborns. Colostrum, which is the first milk that is produced by the mammary glands and what the infant eats for the first few days until the milk comes in, also has a laxative effect, meaning that it also encourages baby to poo more in the first few days of life, which will help clear the jaundice. There are also many ways to give baby breast milk, either by way of breastfeeding, using a spoon, syringe, or cup, feeding tube at the breast, or by bottle. The second priority is to move the milk. The newborn needs the milk to clear the jaundice as well as for nutrition, so moving the milk from the breast to the baby is the second priority. Strategies to move the milk include ensuring that the breastfeeding is successful and done correctly. Making sure that the correct latch, duration, and frequency of feedings is also very important. This ensures that the milk is flowing correctly and at a rate that is healthy for both mother and baby. If breastfeeding is a problem, hand expression is another option to move the milk. When a mother is taught to hand express milk, it will help her with milk letdown, relieve engorgement, help with plugged ducts, and mastitis. Hand expression is also helpful for when the mother is away from her baby because the expressed milk can be given at a later time. Using a breast pump is also another way to move the milk. By pumping, it stimulates the breast and nipples to correct flat nipples and bring them out to begin breastfeeding, or it can be used to pump milk when breastfeeding is not yet established. Pumping can also be used when the infant is not feeding effectively, either with an ineffective latch or not feeding for long enough periods of time. This can ensure that the breasts are being properly emptied to promote an effective and full milk supply. Other devices that can be used are breast shells and nipple shields. The third priority is to help the dyad learn to breastfeed. Giving the mother support and information will make the dyad of mother and baby more comfortable and confident with breastfeeding. The more tools that are given to the pair, the easier the transition to autonomy for them. To help support this pair, it is recommended to continue to give them education about proper latching and effective milk transfer, when and how often to feed the baby, encouraging skin to skin so mother and baby can tell each other when it is time to feed, and create a conducive and relaxed, quiet environment to enhance breastfeeding success. It is also very important for the dyad to refer to the basics of breastfeeding as their guide. Breastfeeding should be established early on and should be often. There should be both effective and exclusive breastfeeding for both baby with jaundice and a mother with flat nipples. The fourth part of the situated decision-making framework is decisions, which is to decide and implement strategies to help the mother and baby overcome the challenges of flat nipples and jaundice. For the flat nipples, the nipples should be ready to breastfeed before breastfeeding begins. This means attempting to erect or evert the nipple so it's easier for the newborn to latch onto. There are multiple ways to evert the nipple. A simple way is called the Hoffman technique. This is where the mother places a thumb on each side of the base of the nipple, directly at the base of the nipple, not at the edge of the areola. Push in firmly against the breast tissue while at the same time pulling the thumbs away from each other. By doing this, the mother will be stretching out the nipple and loosening the tightness at the base, which will make the nipple move up and outward. Cold cloths or ice cubes can also make nipples protrude. Other ways to prepare the nipple are to let the newborn latch to see if she can bring the nipple out by the sucking motion, ensuring that the latch is correct, as well as using multiple positions to ensure that the mother and baby are both comfortable and in the right position for effective milk transfer. As mentioned earlier, there are multiple resources mothers can use to help with flat nipples. And as stated earlier, breast pumps are used to draw the nipple out to prepare for a proper latch, or are used to pump the milk so that the infant can eat via a cup, spoon, syringe, or bottle. Breast shells are also used to apply gentle but constant pressure to the areola in an effort to break the adhesions under the skin that prevent the nipple from protruding. They are typically worn for 30 minutes prior to feeds to avert the nipple. Breast shields are another option for flat nipples, but are only to be used as a last resort. It is a cover that is placed over the nipple during feedings, so it is possible for the baby to latch on. Infants can have problems with being weaned from the shield, and other problems include having an insufficient milk transfer to the baby and a decrease in the mother's milk supply. It is therefore a last resort, and shields should only be used for a short time and under the supervision of a lactation consultant. Helping the baby get an effective latch for breastfeeding is the best option to help the infant with jaundice. Also, ensuring that the time and duration of the feeds to promote adequate milk emptying and the infant getting as much milk as possible for each feed is important. However, feeding is not enough to clear the jaundice. There are other methods available to avoid the worsening of jaundice and becoming pathological. UV light therapy is an option for newborns. This is when the ultraviolet light converts the bilirubin in the skin and blood into the water-soluble conjugated form so it can be excreted from the body. This is a common and reliable way to help the infant clear the excess bilirubin from the body. For severe hyperbilirubinemia and kernicterus, when bilirubin levels are reaching toxic levels, IV immunoglobulin and blood exchange transfusions are available but pose much higher risks for the newborn. The fifth component to this framework is evaluating if what has been done so far has been effective in creating a solution for the breastfeeding challenge. Evaluation consists of following up to ensure that the infant is feeding, there is an effective latch, the milk is moving, ensuring the mother is confident in what she is doing, and is able to monitor her own nipples and breastfeeding. Other aspects to evaluate is if the mother feels supported and if there are resources available to help if she needs further support, and if the mother and baby has learned to breastfeed successfully. In terms of the baby, monitoring of the jaundice by way of physical exam and ensuring that the blood work is improving are other aspects to evaluate this challenge. If the answer to these questions has been yes, then it is safe to say that the clinical decision-making framework has been successfully applied to the breastfeeding challenge, and the healthcare team has ensured that the best care possible for the dyad has been achieved and the breastfeeding challenge has been resolved. To conclude this presentation, we have learned that the challenge of breastfeeding a baby with jaundice and a mother with flat nipples is not impossible. The mother may just need some extra supports in place by way of a lactation consultant, as well as some tools such as a breast pump or breast shield. We have also learned that jaundice can be a very serious illness in newborns if not treated quickly and effectively. Effective feeding and milk transfer, phototherapy, and blood exchange transfusions are available treatment options based on the severity of the jaundice. We have also learned that if successful, the mother and baby can overcome these obstacles and can continue to have a healthy breastfeeding relationship. Thank you so much for watching.